Good afternoon, everyone, and welcome to Fridays with Keenan's Cutting Edge, where we discuss all things edge. My name is Jenna Labourr, and I will be your host as we explore the dynamic world of Don Keenan's trial philosophy, The Cutting Edge. Those of you joining us live this afternoon are receiving early bird access to this episode. You have the opportunity to ask questions and interact with our speaker. If you have a question, please type it into the comments section and we'll be sure to address it. If you happen to be unable to join us live, however, or if you have colleagues, friends, or family who'd like to watch the episode later, episodes are released each week following the live broadcast. So hit that like button and subscribe, and make sure you click the alerts icon to make sure you don't miss an episode. Now, today we have Lil Labourr with us to speak on a condition that many of our clients probably have, but is often missed, both by medical providers and lawyers: vestibular dysfunction, or vertigo. You may notice that she shares my last name, and that's because, yes, she is my mom. I'm lucky enough to be the one lawyer in a family of all different kinds of medical people, from physical and occupational therapists to MDs, veterinarians, nurses, and even mental health professionals. You can imagine the discussions we have about medical malpractice cases. Papa Don asked me specifically to invite my mom to appear on the podcast when he found out that she is a retired occupational therapist specializing in vestibular therapy because of his own experience with vestibular conditions. Our clients often describe this after a car crash or a fall as dizziness or spinning. And I always assumed it was something that was a side effect of a brain injury that I could trust a medical doctor to address. But they do not always truly address it, because often this is more serious than just feeling dizzy. And it's important that we be able to identify the condition to assist when maybe the medical providers are not quite getting it. So if you can identify this condition in your patients, you'll be able to help them get the treatment they need to improve their quality of life. And you may even be able to increase the value of your client's claim. So, Mom, tell us about dizziness and the vestibular system.
Okay, so welcome everyone. Good afternoon. And as you can see, I am an OT. So I am an occupational therapist. And I'll tell you a little bit about my background. I'm, first of all, Jenna's mom. And second of all, I've had a career that's spanned lots of different disciplines. I've worked in pediatrics. I've worked in, with severely and profoundly mentally and physically handicapped children. I've worked in 0 to 3 developmental therapy. I've worked in intense rehab, and I've worked the last 17 years of my career have been in home care. In those years, my most favorite job of all is when I took 10 years off to raise my family. But other than that, when I was in, I'll change this over to the next slide. When I was in home care, one thing that kept on coming up was falls and the reasons why our clients or patients were falling. And we started to really get lots of information and training on dizziness and fall prevention. And then it kind of led into the vestibular system. And I'll go a lot into that so you'll understand a little bit about where that is and that sort of thing. So once we started to really get into the vestibular system and I developed a huge interest in vertigo and treating vertigo, we developed a special interest group in our home care group and have serviced tons of clients that were not getting any care at all and were falling. So what is an OT? It is an occupational therapist, and we provide therapy to a variety of ages and groups and diagnoses. Kind of like a physical therapist, we work hand in hand with physical therapy, speech therapy, but we more focus on the functional outcomes. We work on exercising with people and working on their disability, but most importantly, so that they can be independent in their activities of daily living. And that would be like bathing, dressing, taking care of themselves, getting back to work, whatever their activity of daily living might be. So as an OT, you can work in different settings. You can work in a school, a hospital, you can work in home care, outpatient, and even psychiatric settings. So dizziness. And the reason why I say dizziness is because vertigo is a spinning sensation, but it kind of falls under the dizziness guideline or heading. So why do we care? So dizziness decreases our function. Anybody that's dizzy knows that they have to compromise and do different things in their life so that they don't get dizzy, because it's an awful feeling. It can decrease your ability to remain independent. If you're dizzy or have a spinning sensation, you certainly can't reach down and get something out of a lower cupboard, or you may not be able to work on your computer. It compromises safety because if you're dizzy or you're spinning, it can encourage you to fall over or lose your balance. The other thing is it can do, because it sometimes is continuous or sometimes it's so intense, it can lead to depression and anxiety. So that's why we care about dizziness. So causes of dizziness, there's different reasons, and these are like the 5 main causes of dizziness. Medications are number one. Most medications have side effects, and one of the side effects in most of the medications is dizziness. We try to rule that out. Dehydration is another cause of dizziness. If you're not drinking enough, you can get dizzy. So you need to address that whole issue. Another reason for dizziness is central nervous system disorders, brain issues like traumatic brain injuries, Parkinson's, multiple sclerosis, Lyme's disease, stroke, migraine, headaches. Those can all cause dizziness and spinning at times. Another thing that can cause dizziness is cardiac issues. You want to look into the patient's history and maybe refer to a cardiologist. The fifth, and the one that we're most interested in today, is vestibular dysfunction, or BPPV. Vertigo is kind of interchangeable with BPPV, and I'll go into that a little bit more and what that means. So we're going to look again at general dizziness versus vertigo dysfunction, vestibular dysfunction or vertigo or BPPV. So general dizziness, if you're talking with a client or a patient, they might describe it as giddiness, lightheadedness, or a floating sensation. Those are the general things that words that they might use to describe, I just feel crappy. I just feel like, my head's not right. It's just, I kind of feel dizzy, I think. So looking at that in contrast to vestibular dysfunction or vertigo or BPPV, you're going to get a spinning aspect. There's going to be a spinning sensation of yourself or the environment. You can also feel a self-tilting, that you're tipped over to the side. That's because one of your sides, one of the vestibular systems might be hypofunctioning while the other is hyperfunctioning, and you're going to tilt to compensate. The other thing is clients might complain of nausea and vomiting. And sometimes that spinning sensation can be so unsettling that you do vomit. It kind of feels like when you get off a ride at a carnival, you just feel like you're going around and around and you might vomit. Okay, so what is BPPV or vertigo? BPPV stands for benign paroxysmal positional vertigo. So benign means it's not harmful. It's not like cancer or a malignant tumor or a condition that is going to cause any serious effects. Serious in the way of the spinning, but nothing like a cancer, so it's not harmful in that way. It's paroxysmal because signs and symptoms develop suddenly. It's not a gradual onset. It's usually sudden. It's positional because symptoms can be provoked by the positional changes. looking up, looking down, rolling in bed. I have clients that say, when I sleep, I'm okay, but the first thing in the morning when I get up, the room spins and I have to sit there and wait, and it does stop, but it's just alarming and very unsettling. And the V stands for vertigo, and that's the feelings of spinning or your environment is spinning around you. So it can people sometimes feel like the room is spinning, or sometimes feel like they are actually spinning. Okay. Okay. So functional signs and symptoms of vertigo or BPPV. You can have a spinning sensation, which is primarily typical and present during a vertiginous episode. It's provoked again to repeat by movement, rolling in bed, looking up, bending over, turning your head side to side, making turns while walking. You can have visual impairments, issues with scanning, convergence, focusing, depth perception, not as much the 20/20 acuity part of your eye function, but how your eyes work together. So when they're moving side to side, you may not be able to scan efficiently, and that might cause some dizziness. You could also have impaired walking in the quality and speed of your walking. If you're dizzy or spinning, in particular, if you have vertigo, if you try to get up to walk, sometimes the action of sit to stand can create dizziness. And if you're going to start to walk, you may have to hang on to a chair, or you may feel like you need to walk slower and be more careful and to prevent a fall. The other thing that you can have with a vertiginous episode is headaches, depression, anxiety, and nausea, and again, vomiting. You can also have impaired balance in sitting, standing, and walking. So because of the spinning episode, and also because of the imbalance of your vestibular system, or the dysfunction of one side, might cause you to have significant impaired balance. And again, in an older population, we're cued into that because we want to prevent falls. Let's see this. Okay. Okay, next we're going to go into the vestibular system, the actual anatomy. We're looking at the anatomy, and we can see that this is a picture of someone's ear. And if you look inside your ear, kind of where you put your Q-tip, behind that is the eardrum. So the vestibular system is positioned behind the eardrum, the middle ear, right in through here. This whole system that we're concerned with for treating and diagnosing vertigo is the size of a dime. So if you think of it, if this is actually the size of a dime, which kind of in this diagram is close to that, these canals are pretty small. Just to kind of give you an idea of how small the system really is and how it can really impact your life if it's not functioning correctly. So more about the anatomy. The vestibular system is made up of 3 fluid-filled canals. 3 fluid-filled canals, sorry. 2 otolith organs known as the utricle and the saccule. The canals are positioned horizontally, posteriorly, and anteriorly. So horizontally, kind of positioned this way. Posteriorly, kind of positioned towards the back side of your head. That's this canal. And then anteriorly or superiorly tilting this position so that it tilts this way. So the vestibular system, so in these canals, you will see it's a closed system to begin with. So it's all enclosed. The utricle, the saccule, the horizontal canals, they're like tubes, okay? The canals, the vestibular system helps us know where we are in space. So in these canals, there is fluid. There's also little hair-like fibers called cilia in there also. So every time we move our head, depending on what direction, any direction actually, tip forward, backward, side to side, the fluid in those canals moves, pushes the hair-like fibers, and it helps us know where we are in space. It helps us stay balanced, and it also, this utricle and saccule have different things inside of them that will help us determine velocity. I'm not going to go into it like in huge detail. It gets very, very detailed, and that's why you want a vestibular specialist to work with your client. But basically, those are the structures involved. So here again is another picture. This is kind of almost like a cross section. So if you want to see what's inside the canal, you can see the endolymph or the fluid. The fluid in this part of the ear is, like the vestibule, is more gelatinous and thicker. Here again is the utricle and the saccule. In the utricle and saccule are little crystals. So this is kind of how this is formed. If you see this section here, the little tiny crystals, which are the size of the tip of a pin, little tiny, are in there to kind of help us with velocity and balance. Occasionally, what will happen is if we get a slight bump to our head, or it can be a slight bump or a severe bump, like a brain injury in a car accident or whiplash. I had a client who I tried to figure out if she had vertigo or not. And I said, have you ever bumped your head? Have you looked down? When you look down or up really fast, did it start then? Can you tell me when it started? Was it after a surgery with your head back for a long period of time on the surgery table? When you got up, did you feel like you had this spinning sensation? And she said, no. And then after I continued to treat her, she said, you know what? I do remember bumping my head on a hanging planter out of my deck. That could have caused this vertigo. So what happens, I'm going to go back to this one, is the reason why we care about a bump on their head or any type of trauma. The little crystals that are in these pockets, if you do experience a bump to your head, crystals can pop out. Okay, if they pop out and you go to bed at night, and this whole system turns and you lie on your back, these canals are going to tip over and a crystal might migrate into one of these canals. If a crystal migrates into a canal and you've been lying down all night, you roll over in the morning and you sit up, the fluid in the canal pushes the hair-like fibers and the crystal. And with the movement of the crystal, because it doesn't belong there, the client will suffer a sudden onset of a spinning sensation. So the spinning sensation will start, and it can be intense, it can be mild. And if the patient or client sits there long enough, like, oh my goodness, this feels really awful, I don't know what to do. So normally you'll sit there for a while. And what will happen is if the crystal is in this posterior canal, which is the most typical one, the crystal will settle, maybe in the arm, in the arm here, and the spinning sensation will subside. And then getting up and moving about, you might feel okay until you bend over again to pick something up off the floor and stand up. The fluid in this canal is going to move. It's going to push that crystal and you're going to go, oh my goodness, I'm spinning again. So that's basically what happens when you get a bump on the head, the crystal gets dislodged, and it migrates into one of the canals, and then you end up with a vertiginous episode.
Mom, we have a question from the audience. Is it okay if I ask?
Yep.
All right. We have a question from Joseph Nypaver, and he asks, is it fair to say there is a difference between a diagnosis of vertigo and BPPV with crystals dislodged?
Vertigo can be, you can have vertigo or a spinning sensation for different reasons. You can have a central cause of spinning, like I said, with Parkinson's and that sort of thing. You can have that can cause spinning. But BPPV is when the crystal gets dislodged. Does that answer your question?
I think so. So is vertigo kind of the, well, we'll see if Joseph pops back in with a more clarification question, but it sounds like vertigo is kind of what we describe this spinning sensation as. So it can be a diagnosis, but it also can just be a word we use to describe it. And then BPPV is specific to the crystal being dislodged.
Correct. Perfect. You're learning it.
I'm learning it. All right. Yes. Keep going.
Yeah. Is that good? Okay. All right. Next slide. So as attorneys, what can you do? So at intake, you can ask your patient, your client questions. First of all, you can say, are you dizzy? Or were you dizzy after your accident? And the reason why you want to say, are you dizzy or were you dizzy after your accident is sometimes the abrupt spinning sensation or intense spinning sensation can happen after a car accident, and it can resolve on its own. So sometimes people get lucky and they have vertigo and it resolves on its own. But after the vertigo resolves on its own, you still can have other issues. And I'll go into that a little bit more. So you want to ask, were you dizzy? Did you feel spinny? First of all, have you bumped your head? Yeah, when I was in a car accident, I slammed my head against the dashboard or whatever. Describe your dizziness to me. Are you feeling generally dizzy? Do you have headaches? Kind of general malaise? Are you just dizzy? Or do you have a spinning sensation? Has it ever made you or encouraged you to vomit? Do you feel like the room is moving? Is it spinning? Is the ground wavy? Sometimes people will describe it as a wavy motion. Are you moving? Is any difficulty with reading, focusing on an object, comprehending content of what you're reading, experiencing issues with depth perception? So the reason why we look at eye control a lot is with an imbalanced vestibular system, this one is hypofunctioning or has a dysfunction, and this one is normal or trying to overcompensate and has a hyperfunctioning, you might get issues with your eye control. So if their episode of vertigo has already been resolved, but they're still feeling dizzy and they have eye issues, I try to read, I can't scan across the page. And when I read, I just can't remember what I'm reading. My eyes they're just not quite right. I have clients that, and this is really fun because I have clients when I treat them for their vertigo and it's successful and they sit up on the edge of the bed afterwards, they go, oh my goodness, I can see again. And it's like, what? You can see again? Yeah, my vision is just clearer. And they describe it as if your eyes don't work together correctly, if they don't scan or converge, and you're seeing the environment, but it's not 100%. And then all of a sudden they notice it's clear. So that's really fun. So as symptoms increase with movement, so are your symptoms increased with movement? When you're walking, again, turning while you're walking, stopping, turning around. Oh my goodness, dizzy, looking up, bending forward, turning your head, rolling in bed, sitting up in the morning. You can ask them all these questions just to kind of get a feeling of, Yes, they might have vertigo. Does the spinning stop if you stop moving? That's very typical of a vertiginous episode, or during their vertigo, if they are experiencing dizziness, sometimes they'll say, I have to just stop and breathe, and then it goes away. So the other question you can ask is, are you experiencing a tilting sensation? And again, that's because of the vestibular imbalance, because of the dysfunction. Okay, so how to find a vestibular therapist. Vestibular therapists are typically physical therapists or occupational therapists. So as attorneys, that's kind of what you need to kind of look at. Okay, I think my patient has vertigo. What do I do? Ask them these questions and go, well, I suspect it. So I really want them to be screened for their dizziness or their vertigo to make sure they're getting the help they need. And that's the most important thing. They need help with this if they have it. It's important to refer to a therapist that specializes in vestibular therapy. We have physical therapy clinics all around us, every corner of the street. But if you've ever had an experience with a physical therapist, you might know that each therapist specializes in a certain area: pediatrics, elderly, backs, hands, shoulders, vestibular. I would not want to send a patient that has a suspected vestibular issue to a physical therapist who specializes in shoulders, or an occupational therapist who specializes in hands. So you really have to look for that type of person. You locate a vestibular therapist through state associations. So you might call the physical therapy state association, or the OT state association, the national association. The other group that helps us with diagnosing vertigo are ENTs, or otolaryngologists, that specialize in balance testing or video, and they do videonistomographies, VNGs, to help us determine where that crystal is. Is it in the posterior canal? If I can't figure it out, and I'm going to go into treatment and testing a little bit more, but if I can't figure it out, I look to refer my clients to them, so they will know. They all have their favorite vestibular therapists that they work with. So you can contact them, and they'll help you find the right person for your client. So after you have asked your patients or your clients these questions, you think they have an issue, you might contact their doctor, and you might say, you know what, I think so-and-so might have vertigo. I really want to make sure that this doesn't get missed. So that MD can do the diagnosis. Some of them, they know how to do the maneuver, but they don't know how to treat. Some will try to treat, but to the extent that the client needs treatment and good evaluation, a vestibular therapist should be the one. So lots of times as a clinician, I will get a referral from a doctor that knows a patient has vertigo because they've done the diagnostic testing, and they'll put them on meclizine, which is an antihistamine, and they refer them to the therapist. So we get the client or the patient, and they are on meclizine. They're feeling a little bit better because it is an antihistamine, so it might decrease some of the fluid in their inner ear. But we need to look at that a little bit closer and figure out if we can treat that, diagnose it better, treat it, and get them off the meclizine. So what does a vestibular therapist do? This is kind of the basic premise to what we do. It gets very complicated because you can see the 3 canals. And to figure out what canal the crystal is in, you can't do an X-ray. You can't do an MRI. The canals are too small. The crystal itself is too small, so it's not detectable at this time. They are working on laser treatments to blast the crystal. They're working on all of that, and they will put us vestibular therapists out of business. But right now, we can't see in there. So the only thing that we have to go on is symptoms that the patient give to us when we are evaluating. So the big thing that the thing that we use is the Dix-Hall-Pike maneuver. You can Google this online and you'll get all the information in the world that you want on the Dix-Hall-Pike maneuver. It's a good test. It's a test we use all the time to evaluate and try to figure out where that crystal is and if someone has vertigo. Because we as clinicians want to make sure if they don't have vertigo, we want to rule that out, but help them figure out if they don't have vertigo, what next? Because that dizziness, it's important to figure out how they can get testing for that, get treatment for that. So the Dix-Hall-Pike maneuver is basically, you take the patient sitting up, you turn their head to the right, you help them lie down on their back with their head hanging off the edge of the bed or the table or the surface that they're on, head tilted to the right. And what will happen is you can see the canals and how they'll move when your head is moving. So what we're trying to do in this test is stimulate the movement of any canal in the right posterior canal on the right side, because we do have two. We have a right side and a left side because we have two ears. So this one is testing the right posterior canal for benign paroxysmal positional vertigo. Turn it like that, over like this, roll it over. So what we're trying to do is we're trying to get that canal and we roll it out just like a marble in a tube. We're trying to get the head to move, get the you can see here, get the debris or the otoconia out, move all the way up. And then once we sit them up, hopefully that otoconia or that crystal has moved all around the canal and back into that vestibule, that middle area where the endolymph is thicker, it's more gelatinous, and it'll hang on to the crystal and it will usually dissolve. After we do this treatment, so when we bring them down here, lots of people will go spinning, spinning, spinning. You know, they'll just spin and they'll hate it. I had one patient who she hated it so much. She was an elderly woman and she had pretty severe vertigo. She had been on meclizine for a long time. And she said, you know, put me up, help me up, help me up. And I was like, but I'm not done. And she was like, help me up, help me up. And she almost vomited. And she said, I really do not want you to touch me anymore. That is so uncomfortable. It's so unsettling. I just do not want to do this anymore. And I said, but I think I can help you. You know, went through my whole scenario of how important it was, fall prevention. And she was just happy with waking up in the morning, taking her meclizine, walking to her kitchen table, sitting next to the kitchen table. Her life was very limited, very small, but she did not want any treatment. She did not want to feel that intense, severe spinning that was making her sick to her stomach. So that's essentially one of the maneuvers we do. To do the left side, you just reverse it. You turn the patient's head to the left, bring it down, blah, 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 all the way around. And hopefully once you go all the way around and they sit up, they're feeling better. But this first step here, and lots of times we get a blast on this one. The crystal falls a lot on this one. If you get any positive, oh my goodness, I'm spinning. Yeah, I feel really crappy. We wait till it stops. Between each step, we wait. Oopsie, sorry. We wait till it stops, and then we move them again. So that's how we diagnose for vertigo or BPPV. So if we can't figure out what canal it's in, because there are different maneuvers to figure out the anterior canal and the horizontal canal, there are different maneuvers, and I'm not going to go through all the maneuvers because it's really not anything you need to know. You just need to know that your patient, your client is getting the best treatment from a vestibular therapist. If I feel like I can't tell what canal it's in, I might refer to an otolaryngologist or a balance center for a video nistomography. This is a test that they do. It's similar to the same motions of this, but they put goggles on, and the goggles are hooked up to a computer, and the computer is sensitive to the movement of the canals. And another whole thing that we look at, that the goggles will detect, that we try to detect, is eye movement. When we bring the patient down, they need to have their eyes open. If their eyes are shut, it's really difficult to determine the canal. If their eyes are open, we look at the eye, and the eye will actually spin, or the nystagmus will actually move towards the canal that the crystal is in. So it moves to the right, it's the right canal. If it moves to the left, it's the left canal. If it flips up, it's anterior. There's a whole bunch of things, but looking at the eye is key. So they always have to keep their eyes open. So the otolaryngologist, the balance center, the ENT will have that instrument, and they'll be able to tell us specifically what canal it is, and that will help us with treatment. If we have a negative and we can't provoke the spinning, if we can't get them to spin, then we start to look at other things. Okay, they complain of spinning and dizziness, but I can't make it happen. I don't think there's a crystal in there, because when I put them in these positions, I'm not getting the response I normally am looking for. So they might have other central issues. And when I talk central, I think of brain. We talk brain versus peripheral ear. Central brain, peripheral ear. Central, like the Parkinson's again. Lots of people have spinning and all kinds of issues because of their eye control issues, because of just the disease itself. So we might end up saying, okay, I don't think I can help you, but let's have you go see a neurologist to rule out anything else. That might be central, your brain. We might also refer to a cardiologist, because lots of times with cardiology, with cardiac issues, you can have dizziness and some spinning just because of your occlusions with your blood and narrowing of arteries, et cetera. The other thing we might do is, if we really just think it's medication related, in home care, we have nurses that'll do med reconciliation and try to get patients' med lists organized so that they're not on too many medications and maybe off of things that they shouldn't be on. And that will help with dizziness. So those are things that we look at as a therapist. We want to treat the vertigo, but if we can't, we really want to help the patient with dizziness. So the treatment, once we figure out where the crystal is, and what we want to do is we want to treat it. So we use the Epley maneuver. Again, you can Google that and you can see that people actually even treat themselves. You may know someone that has had vertigo, or you may have had vertigo yourself, and they just go online and they look at the maneuvers. And if you're lucky, you can treat yourself, and it can get better, because it is usually the right posterior canal that's the most where the episodes occur most often. But again, it's lying down, rolling, head to the right, head to the left. It's the whole scenario again. And we will repeat that maneuver with our patients. And each time we repeat it, we don't move them from one stage to the next until the spinning stops. And we will notice over time, depending on how many treatments we do, that crystal will eventually roll out and the patient will be symptom-free. Or at least the spinning will stop. they may have some residual dizziness. So after the BPPV is resolved, or we have a negative Dix-Hall-Pike maneuver, we continue to keep seeing the patient to make sure there isn't anything else wrong. We look again, like I mentioned earlier, we look at their oculomotor system or their eye control. I had a young guy, he was in his 20s when I was working in outpatient, and he was a Mercedes-Benz mechanic. And he came in and he said, you know, I crawl under my car that I'm working on the engine, et cetera. I go to get up and I have this horrible spinning sensation. And I said, okay, let's look into this. And sure enough, he had BPPV. After doing the Dix-Hall-Pike maneuver, we did a few sessions of the Epley maneuver, and he said, I feel great. Came back the next time. And I said, okay, let's look at some other things. I said, how's your balance? And we looked at his balance. I said, how's your eyes? He said, oh, my eyes are fine. And I said, you don't have issues with reading or any of that? And he said, no, I'm fine. So then we started talking about some other things, his strength, et cetera. And he said, well, you know, let's get back to the vision. He said, you know, I just feel like I have to look at my phone several times to read my texts. And I said, okay, what we're going to do is we're going to look at the vestibular ocular reflex. So this is where it kind of gets a little more complicated. And I don't think you really need to know what we do, but in particular, unless you really have a specific question about it, but we do look at vision, and there is a connection between the vestibular system and the oculomotor system. So when the vestibular system, as I've said 100 times in the past, if the vestibular system is impaired or has any type of dysfunction, your oculomotor control can suffer the same way. So we can get rid of the vertigo, but then you'll have an imbalance. So even though the vertigo is gone, we may need to do exercises to get that side of your vestibular system so that they're level and normal. One of the things we do is head turns, head shakes with focusing up and down, and it just goes on and on. So we did I gave him homework, and he did his vision exercises, and he came back the next week and he said, I'm totally fine. I have no issues left. And I was like, yay. Yeah. So anyways, the other thing we look at is balance systems. We want to make sure that even after we have resolved your episode of vertigo or BPPV, we want to make sure, due to any imbalance in your vestibular systems, we want to make sure your balance is okay. So we may take you through, you know, things to stimulate your balance and get your vestibular system stimulated so that it's normalized. We want to check the functional activities. Again, in home care, mostly with an older population, you may not have the spinning anymore, but you may have eye control issues. You may have some general dizziness because of the vestibular imbalance. So we want to make sure you're safe. What adaptive equipment can we put into place so that you're not maneuvering your shower and your toilet and all those kinds of things unsafely. We'll go through strength and mobility. Also, if I'm an OT and I saw a patient for vestibular therapy, and when they came to me, they were using a walker because their balance was so bad, say after a knee replacement, and they were on the table for way too long, or typical amount of time, and they woke up with vertigo and they had to use a walker because they were so dizzy. After I get rid of their or help them resolve their vestibular episode, I might refer to PT, because now the patient can work on more aggressive exercises and get back to walking without an assistive device. So there's also the whole idea of not treating it. If a patient ends up having vertigo and it never gets treated, it can go on for weeks, months, and years. People will just have symptoms for a long time. And all these symptoms can compromise a patient's or client's safety and function. So if you have an elderly or an older patient that's been in a car accident and the vertigo never gets resolved, it's huge. It really will compromise their life. I have patients, so I'll go, so are you dizzy anymore? No, no more dizziness. And I'll go, oh, okay. So can you bend over and get something out of this cupboard? And they'll go, oh, I don't do that. And why? Well, because it makes me dizzy. So they'll make changes in their life so that they don't have to do the activities that cause dizziness. And then they think they're not dizzy anymore. And that's not normal, and it's sad. Okay. BPPV sometimes can resolve on its own. In some cases, the crystal can dissolve or be repositioned by normal rolling in bed, sitting up. So someone can feel like they've had vertigo. Then they go to bed and they roll, or with normal daily activities, that crystal rolls back out and they've cured themselves. And that's a good thing. It's also noted that if a patient has an episode of BPPV and it gets resolved, their tendency for it to reoccur is 80% higher than someone who's never had it. So if you've had it before, there's a good chance you might get it again. It's also noted that we all have a really good chance of having vertigo by the time we're 80. The incidence just increases as we get older, and they still don't really know why. They don't know why. They don't know if it's the way the system is positioned in our head. As we get older, our posture changes, which might increase tendencies, but they're still, I'm not aware of any reason. I think that's it.
Awesome. Thank you so much, Mom. That was super helpful. All right. So we had the one question, and I just took a couple of notes to kind of fill up the rest of the time here so we can just chat. You good with that? Okay.
Yeah.
So I remember when, I guess when you were kind of starting out and getting involved in the more specialized vestibular part of your practice, you often told us lots of examples and stories of patients who'd had this condition for a really long time, and they had been treating with all kinds of providers, but nobody had really pinpointed this vertigo or BPPV thing. Can you talk a little bit about how often it's missed, even by super good and providers who have their hearts in the right place and are trying to help, and why it's important for us to know a little bit about it so we can assist both the provider and our client with getting them the help they need?
I think patients get missed because when they go into their doctor and they're asked, they may not want to say that they're still spinning. They may not want to complain that, yeah, it's still going on. The doctor has tried to give them different medications, and the doctor has tried to, help them. And then finally they say, oh yeah, I'm fine with that, because they have changed their lifestyle so much and compromised it, or have gotten used to it, or know how not to make it happen, or know that if they stay still, it's going to stop. And some people will just live with it. The other thing that can be controversial is there are some medical professionals that really don't have a lot of faith in vestibular therapy. So they may choose not to refer for reasons that they think it's not scientifically based, or there's not enough information, or they just don't know enough about it. So they're skeptical to refer their client or their patient to a vestibular therapist.
Okay. And then, so if we have this background that you shared with us today, then we might have a doctor who, or a patient who, or excuse me, a client. We have clients, a client who is complaining of dizziness, and we feel like the provider isn't addressing it. Then we might be the ones who can say, maybe vestibular therapy is an option we should try.
Right.
Okay.
Right. Exactly. And you'll have to determine with your client if you can just refer to a physical therapist or an occupational therapist without a doctor's order. Now we all are getting our doctorates as PTs and OTs, and we can sometimes practice without a physician's referral. That's all things that you need to work out with the patient. If you feel like they've got a spinning sensation or significant dizziness, and it might be from something that happened to them related to your lawsuit or issue, then it's up to you, and you need to get that patient help. Because if the patient or client is telling you they're dizzy and the room is spinning, then it's got to be significant enough.
Right, we have another question.
Oh.
So Byron McLean says, this is so interesting. Mm-hmm. During my undergrad years on campus, I often observed one gentleman walk along, pause, side flex his head to the right, spin 360 degrees, then proceed in one motion. Have you? Oh. All right. So, Mom, have you ever? Is that something that you would think is vertigo or BPPV related or vestibular related if you saw that kind of behavior in a patient?
It could be, I really can't say for sure because we don't really know if that person had anything else wrong with them. Were they stopping because they needed to regain balance, because they had Parkinson's or MS or something, and they were able to, or were they stimulating their vestibular system? It's a possibility. You see all kinds of things.
I had a client recently, and I think I shared this with you, but she had a brain injury from her car crash, and we sent her to all the usual things that lawyers send their clients to: neuropsychologist, neurologist. I mean, we had her see everybody, and they were like, well, I mean, her cognition is fine, and her memory seems to be okay. It's affected a little bit, but we can't really tell what's going on. And she kept complaining that she couldn't watch movies or follow the script of a movie or read or remember what she was reading. And she specifically claimed that in her small kitchen, which was kind of closed and square shaped, when she turned around within that kitchen, she would almost fall over. And I wish I had mentioned that to you earlier on, but it turned out she went to see a physical therapist for vestibular therapy. They did some vision therapy, and it fixed it. Yeah. So it's really important, everybody who's listening out there, that we address this. And even I, honestly, because my mom's been doing this for a long time, I grew up at the dinner table hearing stories about patients, and I didn't even pick it up in my client. So put it on your checklist, put it on your intake. Make sure you're thinking about it with falls, with crashes, even in a crash where maybe your client doesn't remember hitting their head, because 99.9% of the time they hit their head on that headrest, whether they remember it or not. And that's something so simple because of how Mom explained the very tiny and sensitive nature of that system. It can dislodge the crystal, or it can traumatize that system. What other thoughts?
Yeah, and it doesn't even have to be a hit on the head. Sometimes it's just a whiplash where the stimulation is high enough. And I think I neglected to mention that we also, as vestibular therapists, work closely with developmental optometrists. We, if I feel like I'm plugging along, making a lot of progress, but I just can't get that oculomotor system that I control, the vision working correctly, I will refer to a developmental optometrist. And I have one that is in our area that is phenomenal. She's nationally known, Dr. Torgerson, and she has a vision therapy clinic, and they will take care of and work with you back and forth as a therapist. And so we can get those things that we think probably, it doesn't matter. But when you're living with impaired eye control, it does matter, whether it's from, in this case, it's from BPPV, but it could be from a stroke, et cetera, or you're born with it as a child. But.
All right, we have another question from Philip Fabiano. He asks, can vestibular issues causing depth perception problems be independent of convergence insufficiency? In other words, convergence insufficiency improved, but depth perception still a problem. So can those two things be independent of each other?
I usually see that if someone has depth perception issues, as an occupational therapist, I screen vision all the time for our elderly patients. And usually if they have depth perception issues, they have some type of an eye control issue, and convergence can be a culprit. Either that, or they don't have any convergence at all. One eye deviates out, and that occurs. I'm not saying it will never happen. If you have an issue with vertigo and you're spinning and you try to negotiate a step, you're not going to have good eye control, period. Because your eyes, if you look at someone who is spinning, this gets into it a little bit more. If you actually look at someone's eyes when they're spinning, or you will see their eyes will twitch. It's called nystagmus. And that alone, you can't focus on anything. So your depth perception is going to be impaired. It's like when you literally get on a carnival ride and you're going around and around in circles. You probably all remember that as kids, maybe not, but I do. You get off and you can't even stand upright. Your vestibular system has been so overstimulated and your eyes are going back and forth. If you look at your friend's eyes after they get off that tilt-a-whirl, their eyes are twitching, and that's nystagmus. That's normal after overstimulation of the vestibular system, but not normal after a spinning sensation because of a turn or, that kind of thing. But yeah, that nystagmus can cause, probably a depth perception at the time it's happening.
If you sent somebody that you saw had that condition to Nancy Torgerson or somebody like that, and they kind of fixed the eye issue, would that also fix the depth perception issue, or could the depth perception be something that?
The goal is to fix the depth perception issue. Mm-hmm. So if your eyes are working correctly, they're scanning back and forth nicely, they're coming in and going out nicely, converging and diverging nicely, your depth perception is going to improve.
Okay. All right. Okay.
Well, it's the same example as your sister.
Oh, yeah.
Another just vision therapy thing. This is a segue, but my other daughter had issues with convergence. She had a pretty significant convergence insufficiency. It was just something she was born with. So she went to vision therapy, and after 3 weeks of vision therapy, she said to me, I said, "How are things going?" And she said, "I don't have headaches anymore." She was having headaches when she was reading all the time. So it's really important for us to, whether you're born with it or it's a result of a traumatic brain injury or whatever, we need to get our patients the help that they need. And
Yeah, that's super interesting because all of this stuff is connected. I mean, when you think about it, this is a very small area of your whole body, and it's so close together. And I never even thought about that. I forgot. I mean, you, Aubrey, had that, but I forgot that there was the symptom of headaches, right? Yeah. And so many of us have clients that are like, I have headaches. I don't know that I would think to say, well, how's your vision and how's your balance? Mm-hmm. Because maybe your headaches are from your eyes having to work too hard because there's an insufficiency there. And
you had
movement.
You had vertigo for a little bit after your episode, your car accident, or, it's being a detective, and you guys know about detectives. So it's really being a detective and getting as much information as you can to get your client the help they need, whether it's vertigo. I love ruling out vertigo because then I can send the patient to somebody else. But I also love treating it and making them better. Yeah.
Yeah, that's neat. Tell us one of your favorite stories about a situation where you were able to make a difference in someone's life because you detected this condition.
Oh, my favorite story. Now I'm going to probably remember later. I love the
Mercedes story. Nobody will know if it's your favorite or not, really.
Yeah, I love the Mercedes-Benz story because this guy was so young, and he looked at me like, "Yeah, I can read," or "Yeah, But I was like, "Well," and then when I helped him, he was like, "Oh," that sort of thing. And my patients who sit up on the edge of the bed and go, "I can see again." Trying to think, patients who typically you'll go, okay, this is what we're going to do. We're going to roll you on. In home care, we roll people on their beds. So we have to go into their bedroom. We have to get kind of up close and personal with them, get them on their bed. And they're very skeptical because they're wondering, you're going to roll me around on my bed. How is that going to make my spinning go away? And we do a lot of education. We show them the diagrams. We teach them about the crystal. We prep them for what we're going to do and why we're going to do it. But they're still very skeptical. But when they sit up, or when you talk to them the next time and they say, you know what, I'm not spinning anymore. It's just, it's awesome. It really is. I don't know. I can't really think of a specific story, but.
So when you do that maneuver and it helps, is that it? Does that mean they're cured? Or, because I know you talked a little bit about the fact that you do some follow-up to explore other possible conditions that might be occurring, like vision and other things. But is it just one visit with that treatment, or do you have to do it multiple times, or how often do you do it?
Sometimes you have to do it multiple times. You have to do it multiple times to treat the canal that you know it's in, or you have to do more evaluating to figure out what canal it's in. Sometimes it can get really complicated because the crystal can get stuck on the, and it can become cupula on the cupula, and in a gelatinous in the ampulla. I mean, it just gets more complicated. So if the crystal gets stuck in the ampulla on the cupula, and it becomes cupulolithiasis, so it's stuck on there, but every time the person moves, they're still spinning. We have to do a maneuver to whip that crystal off there, and it's a slamming down kind of maneuver to jar that crystal loose, so that it continues that way. But lots of times after vertigo, because that one, say it's on the right posterior, which is the most common, that right side is going to be sluggish. So when the person turns their head, this one's going to be functioning okay, but that fluid in those semicircular canals, this one's going to be a little slow because it's had that incident. So we'll do a lot of head turning, head shaking, eye control type of stimulation to get the balance between the two systems up. So if you get a good vestibular therapist, there usually is, I don't know, I guess you could say probably, I don't know how many visits, depends on the patient always, but there's usually good follow-up with all of that. Mm-hmm. You look at your dynamic visual acuity. There's just so much that you do that it's just so much fun. But yeah, you would expect, so if you did bring your patient or client to a regular physical therapist that does kind of a bunch of different therapies, oh yeah, I can do vestibular therapy, and they clear the BPPV and say they're discharging, and this client of yours is still dizzy but not spinning that much, you might want to look into getting someone who's a little more specialized, depending on how much the dizziness is affecting their life. But as a vestibular therapist, it's not a one and done usually.
Okay. All right.
Yeah.
All right. Well, thank you so much, Mom. And thank you to all of you who joined us for this week's episode of Fridays with Keenan's Cutting Edge. If you liked today's episode, please click that thumbs up button and don't forget to subscribe and sign up for alerts so you don't miss the next one. Next week, we will be hearing from our very own Mindy Bish, a lawyer at the Keenan Law Firm who also heads up the Tractor Trailer Referring Attorney Group. Mindy will be speaking to us about what's new with the Tractor Trailer Group as part of our New Revolution series. My partner, Young Ji Ham, and I were fortunate to work a tractor trailer case with Mindy and the Keenan Law Firm last year, and it was an incredible experience. So I'm excited to hear about developments that are new with all of you. Have a wonderful weekend, and I'll see you next time.